know that prostate cancer is the most common cancer in men in the Western world, and most patients are diagnosed with early prostate cancer. Now, when we see a patient with early prostate cancer, we try to risk stratify him to know whether he can be only under active surveillance, no need for therapy, or do we need therapy. And the most common system for risk stratification today is the clinical system, the NCCN system, based on the PSA, the Gleason score in the pathology, and the clinical stage that we evaluate, per physical examination, MRI, PET-CT, etc. Now, we know that this risk stratification into low, intermediate, and high risk could either over stratify patient into high risk, or take patients that are so-called low risk, but actually they have a higher risk. There is a big heterogeneity among the patient, and we really take treatment decisions based on this risk stratification. Now, we know that Decipher Genomic Risk Stratification, which is a test that takes the pathology of the tumor and check the presence of 22 RNAs, and then they build a kind of algorithm to stratify the patient independently of the clinical factors into low, intermediate, and high risk. And we know that the Decipher is probably more accurate in predicting the risk of patients. And from American data, mainly American data, we knew for some time that patient might change the risk grouping based on the Decipher versus the initial clinical group. But we have almost no data in non-American patients. What we took now, we took a cohort of non-American patients, and indeed we saw that also outside of the US, when we do the Decipher test, we could change the risk stratification of the patient under either the patient will have a low risk or a high risk, and accordingly it will impact our treatment decisions. We saw that a significant percentage of patients with NCCN low risk, or what we call favorable intermediate, that potentially could go into active surveillance and with no therapy, actually per Decipher they had a higher risk, and we recommended this patient to undergo therapy by either surgery or radiation and not wait and be under active surveillance. On the other hand, patients that we thought they had a higher risk, like unfavorable intermediate or high risk per the NCCN, actually per Decipher that they had a lower risk, and we could try and de-intensify the therapy. Yeah, I think that actually the Decipher is mainly used in American patients in the US, and I think that clinicians worldwide should consider using this genomic test to better risk stratify patients, regardless of whether they are American or non-American. So a second question we asked is, are there any differences between the American and non-American in terms of transcriptomic profile? Because the Decipher will give us, in addition to the risk stratification, a whole transcriptome. And we know that there are geographic variation in prostate cancer, gene expression, and tumor regenesis processes. And actually, we did find that in similar patient per the NCCN risk, American versus non-American, we found that the transcriptomic risk was higher in non-American versus American. And this is something to continue the research about, to see could it impact potentially the therapy.